let's get into the internal medicine program requirements. So I'll talk about the requirements, again, at a high level, the general process that we went through, our experience, and the challenges and good outcomes. So common requirements, that's the same for all programs, whether you're internal medicine, family medicine, whatever it may be. They're the same requirements. It has to do, a lot of this is repeat, but the institutional requirements, so making sure you have your sponsoring institution and the participating site and program letter of agreement for all of those, which I'll get more into the detail of that on a future slide. The program personnel and resources, so that's the requirement of your program director and your core faculty. They have the common requirements of resident appointments, like who is eligible, what's the process of transferring, what's the number of residents you may have, and what are the requirements on other learners. The education program, and really with these, it's all terms of competency-based, and they have competency-based goals and objectives on the education program, and they all adhere to the ACGME competencies, and I'll get into that a little later. And then there's requirements as far as evaluation. As you talked about, the clinical competency committee is responsible for that, and there's different forms of evaluation that are done. And then the overall learning and working environment. So for internal medicine, this is more specific for internal medicine. So institution, the residency program must be in the Department of Internal Medicine. Well, we didn't have a Department of Internal Medicine, so right off the bat, that became an issue for us. And it was interesting because the application common application allows you to say whether you have one, and if you didn't, they just wanted to see your org chart, which we did. But then when it came for the site visit, and then you read later, you have to have one. So it was a little confusing. So we developed the internal medicine department.
The day before.
Yeah, we used to have one. Then we combined adult medicine, whether you're family medicine or internal medicine, they came together. And then they're separate pediatric and OB. Well, because of our residency program, we had to separate out internal medicine again into its own department. There's specific salary support and hours for the program director and the core faculty, and I'll talk about that later. There's requirements on inpatients, so the number of times that they can be on night float rotations, the reporting structure, like how many residents can report to how many attending. They must be supervised by internal medicine physicians, and there's a limit on the number of patients that they're assigned. And it's a lot of detail, and it's all in the manual. Participating sites. So you need a PLA or a program letter of agreement. And within that program letter of agreement, it's needed for every participating site where there's a required rotation. So cardiology is required, ICU is required, inpatient is required. You have to have a program letter of agreement. And you identify the specific faculty that's responsible for education and supervision, the responsibilities for teaching, supervision, and evaluation, the duration of that rotation and the content of the educational experience, and then the policies and procedures of government. That all is within the program letter of agreement that is needed for each site. These are the requirements on the personnel. So for internal medicine, 50% of their time needs to be dedicated to the education and administration role of the program. They must have 5 years active faculty experience in an internal medicine residency program and 3 years of administrative experience. The faculty, they have to have demonstrate some scholarship. It doesn't say specifically what. There's different categories that you can go under, whether it's presenting at national organizations, whether it's being books, journal articles, peer reviews. There's different elements that will meet that requirement. And then the associate program director, actually internal medicine currently does not require an associate program director if you have less than 24 residents. We elected to have one anyway. I agree that you just need more people to help run the program. So I had the physician that's going to run the inpatient be an associate program director so that she can help from that end. But they have to have 50% of their time allocated to teaching and for the education and administrative role. You have to have subspecialty education coordinators for all the required rotations. So like cardiology, ICU, rheumatology. You actually identify somebody and they're called a subspecialty education coordinator. And then the core faculty, which the minimum is 4, they have to at least have 16 hours per week that's dedicated to the program. So the core faculty will be our base faculty. With the family medicine program that we currently have, they have their own core faculty, and then we as an organization have supplemented that with additional providers that we allow to be part of the faculty also. And then resources, the facilities and clinical support, specialty services, the on-call facilities and patient population, all of that is defined. They want to make sure that you are going to give them the experience they need, that you have a good variety of patient populations by gender, by age. So all of that needs to be submitted with your application. Residency appointments, again, it goes into a lot of detail on the criteria of who's eligible for residency and who may transfer. The minimum number of residents in internal medicine at any given time actively participating is 15. So I thought about it. If it's 3 years and we only have 5 residents, all it would take is one person not making it through and not being active, and we would not be compliant. So we went with 6 per year. And then other learners, again, those are your nurse practitioners, medical students. You just have to report it to the DIO and GMEC and make sure that it's not interfering with the resident education. So the basic requirements on the education for internal medicine, obviously 36 months of supervised GME, at least 1/3 has to be ambulatory and at least 1/3 is inpatient, and the ER can't account for more than 2 weeks of the ambulatory time. There is no specific requirements on number of inpatient medicine rotations, number of ICU. They don't specifically lay that out. Competency-based goals and objectives for each assignment, that is probably one of the most time-consuming portions of your application. But you really, ACGME has their competencies, and everything you do is centered around those competencies. We are required specific requirements on subspecialties, procedures, and outpatient clinics. So it'll define the procedures that the residents need to become competent in, and so it's best to build those into your goals and objectives for the rotation. The required ratio is 4:1, and I agree that's pretty high. I think 2 to 3 to 1 is better if you can do that. There's also the regularly scheduled didactics that you have to have, the integration of the competencies into the curriculum, and then scholarly activities. It doesn't exactly say what that has to be, but you do have to provide that in the program. We're fortunate we have a large, which is unusual for a federally qualified health center, we have a large research and development, research and health promotion department. We have NIH grants that we actually are the receivers, and we're sub-recipients on other NIH grants and other studies going on, whether it be with UCSC or San Diego State. So scholarly activities will be able to achieve that. It's sort of hard if you don't have all that support going on. So the competencies, I mentioned this because you're going to see it a lot on the application. There's 6 of them. Patient care and procedural skills, that's what it sounds like. That they, provide compassionate, appropriate, and effective care, and they're competent in their medical knowledge, or medical care, and their diagnostic tools, and their surgical procedures. Medical knowledge, that they're able to apply that knowledge to patient care. Practice-based learning and improvement, that's related to sort of the self-evaluation and lifelong learner, so that they're always evaluating their patient care and assimilating that information and constantly improving. Interpersonal and communication skills, and that's not just with patients, but with their colleagues, with their support staff. Professionalism, big, I think is a focus. So it's not just your basic integrity and honesty and compassion, but it even goes down to being culturally sensitive to different patient populations. And then the systems-based practice, that's related to just the general awareness and addressing the overall, the larger health system. So they're concerned about resource utilization, they're concerned about cost of care, and they think about that and they implement changes related to that. So the evaluation for the residents, there's, as we mentioned earlier, the clinical competency committee. It has to have a minimum of 3 faculty members. The resident evaluations are based on those competencies that we talked about, and they have a per rotation, semi-annually, and summative. So that's the end of the whole residency. The faculty, at least annually, needs to be evaluated, and then the program itself has to be evaluated. There's actually a program evaluation clinic that was mentioned, and that has to have at least 2 faculty and 1 resident on that committee, and they will annually evaluate the program. As far as the learning and working environment, always taking into consideration patient safety, quality improvement, supervision, and accountability. They define the levels of supervision, and we actually have a policy on what defines that, but whether that's direct, indirect, and oversight, and how they reach those different levels. So direct being you're right there with them supervising, indirect is you're maybe in the building or get access to you quickly, and then oversight is more remote type of, don't have to be right there with the resident. But that within the committee, the clinical competency committee, they determine when people keep moving up into these areas. Professionalism, again, big, a lot of training and just monitoring of professionalism, well-being. We actually have a provider well-being committee, so we're addressing this, and they will be part of that committee. Fatigue mitigation, that everyone's trained on that and they understand it, they can recognize it, and they do something about it. Clinical responsibilities, teamwork, transition, and care, all that really has to be stressed within the working environment, and we have to teach it. And then clinical experience and education, again, that's related to your work hours and even moonlighting, call, all of that, that you have that. There's a lot of rules that regulate that, and you have to follow them. So the general process, obviously download the document. So there's 2 manuals. Again, when you apply, you apply not only to the, there's not only the common requirements, but there's the actual specialty requirements. Equally with the application, there's 2 different applications. You submit them together, but you have to do both. The whole, I mean, if I look at our application, there it is. It's pretty big. There's a lot of stuff that goes into it. So the first steps, I think, in the overall process of this is, again, identifying your participating sites and getting your block schedule down. That was, again, my biggest downfall. Everything depends on that block schedule. That depends who your participating sites are. That depends, I mean, that affects, like, your residency manual. Everything is related to that block schedule and what their schedule is going to be, how you're going to meet that schedule. So defining your block schedule, even to the point of whether they're going to have continuity clinic longitudinally or 1 month at a time, it all is built into that block schedule. And throughout the application, you're filling out information related to that block schedule. So every time I change my block schedule, I have to go and change my application. So figuring that out up front, I think, is really a learning point for me as a listener, and you kept telling me that, defining your block schedule, and I'm not sure, but, and it really defines what your program is about and what you want to focus on. Because again, in the internal medicine, there's not a lot of specific things that they say you have to do, so you have to decide how you want to do it. Also developing a general program letter of agreement up front, and then from that point forward, you can use that same format for all of your participating sites, because you do need to send those out based on your block schedule. It's important on the general program letter of agreement, I think you taught me that, some of the requirements we did as attachments. So you could use the general format and then the attachment of some of the requirements. That way we could get them done quicker. Again, the key personnel, I won't go through that, but one of the points on this is collecting the CV. The application requires a lot of detail on all of your, not just your program director, not just your core faculty, but all the subspecialty education coordinators, so the cardiologists, internists, intensivists, all of that. You need to have specifics when they graduate from medical school, when they last got board certified. So we were collecting CVs up to the last second. I get commitments from people, and, oh yeah, I'll send you my CV, and after the 10th call, you finally get a copy of their CV so you can fill out the application. So the sooner you can start collecting those, the better. Plus it also lets you know whether they qualify. Meet with faculty and program directors to define and develop the program. Again, this is their program. It's not my program. I'm responsible for the oversight, but the program director and the faculty need to know what their program is, develop it together, because they're the ones that have to meet the requirements. Defining faculty training and develop a faculty development plan, so there's specific areas that they need to be trained in annually, and so that needs to get set up. And then conducting the training on APGMA competencies. We trained all of our faculty on that so that they were aware of how they had to train with the residents. Identifying and developing policies and procedures. There was a lot for the Sponsoring Institute. You're going to have a lot more here. So again, it's a lot of GMEC meetings and going through these policies and procedures and approving them. Identifying your CPCA and PEC committee members and creating that policy. You have to develop goals and objectives for each rotation. I can't stress enough how long this takes. So really, by rotation, it's not only by rotation, it's by year of that rotation. So you have to define the goals and objectives for PGY 1, 2, and 3, and within that, by competency. So it's not easy. And then what I did is incorporated all the procedures that were required for them to learn. I incorporated them into each of the rotations. And then just developing your curriculum to meet the competencies. During the application, it's going to ask you describe a learning activity where you're going to address professionalism. So you really have to understand those competencies and make sure that not only your goals and objectives address them, but even some of your didactic and training. And then how you're going to evaluate people. So in order to meet those competencies, you're going to, whether it's direct supervision, whether it's going to be through a standardized test, through the mini clinical exams, whatever it may be, how you're going to address each of the elements, and that it will be a method of evaluating the residents. Developing a didactic program, so what topics you're going to cover throughout the 3 years. During the site visit, they're going to ask you for a 3-year plan by year of what is going to be included in your didactics. Develop a quality improvement program if it's not already in place. Most of you should have that if you're involved with an FQHC. So it was easy to meet that need. Develop the program for the scholarly activity. So not just that they're going to do it, but how you're going to do that. Whether it's going to be 1 month that they just work on that, whether it's going to be longitudinal, you have to define all of that. And then the residency manual sort of holds it all together. So that was probably the last thing I finished up until the last minute. But it really includes things from where their lockers are when they're in the hospital or in the clinic, or how they're going to get their meals, or if they want leave, what do they need to do? Anything the resident needs to know, how to reach the DIO, how to reach the core faculty. Anything they need to know during those 3 years needs to be in this residency manual. And there's no format. It's not like they tell you include this, this, and this, but it needs to be there somehow. Our experience, timeline, we had a timeline set out. I don't know if we exactly followed it, but we at least knew what we needed to meet. Really understanding the requirements for both the common and the internal medicine programs, formalizing all our partnerships, gaining commitments from the specialty partners. So some of the ones that aren't required rotations, you still need to identify someone that's going to will be available if the resident wants to do that rotation, like dermatology. It's not required, but you need that option available. Again, the block schedule really is the difficult part of putting that together. Going through the policies and procedures, creating the evaluation form. Initially, when I was doing that, I thought, oh, just regular, performance evaluations. That's easy. No, it's not. They're pretty long. Getting your goals and objectives. That was the manual. So once all of this is done, you can get your application and submit it. Again, these are just my challenges, which I already mentioned most of these with the block schedule, the commitment from the subspecialty coordinators. Not that I didn't have no's, it was just the time commitment of actually meeting with all these people and explaining to them. And it's some ways hard to sell a program that doesn't exist. So when are you going to start? I don't know. When are you, everything was, I don't know, but we want to do this. The CVs, I can't stress enough collecting those. It was probably one of the hardest, and the doctors all meant to send it to me. It's just, they're busy. The goals and objectives were a challenge. The evaluation tools were a little bit difficult to make sure that you met all the competencies. And then, again, the residency manual. Surprises is no different than what we had before. Just really the support we had, the commitment and excitement we had. The only difference is just the variety of the evaluation options. Really have to put a lot of thought into what type of evaluation meets what need, and so that you make sure that you're evaluating, you can evaluate correctly whatever it is that you're trying to evaluate, whether it's a core competency or a procedure, whatever it may be. Yeah. So then, did you create those evaluations manually yourself, or because I know there's a suspender? Oh, no. No, I felt really bad. No, I went online and because I was struggling with those, and I didn't really understand how to do them. So I went online and started looking at different sites and not trying to reinvent the wheel, but just found out how other people did them. Dr. McKenna allowed me to get into, because I'm faculty with there too, so I went into the new innovations and was just looking at some of the evaluation forms. I actually overlaid one of hers, which I felt really bad about. That was an accident. But yes, I created them myself with help, like getting samples of other people, but yeah, put them together and then put them into new innovations and printed them out that way.
The key to that is most folks at the application stage are not going to have access to new innovations.
Right.
Or MedHub or MyValve or
right.
any of them. So what you can choose to do is call them and say, look, I'm doing a new program. Will you give me some access, or will you send me some samples or things like that? And most will be pretty helpful, but you really got to be ahead of the game on that if you're going to have that happen.
Especially, center program with a copy of all our curriculum, a template for program letter of agreement, sample block schedule.
Wow.
Yeah. I mean, it sounds pretty straightforward, but, so like our program, granted we're a big program, we have 161 program letters of agreement and 49 curriculum. So not everybody's going to get to that, need to have that kind of level, but I mean, even for a program of, 18 residents, you're going to probably have, if you haven't already, you're going to get more. You're probably going to have, greater than 30 or 40.
Yeah,
it's a big list.
It's a lot of detail on that, and it really is. I'm family medicine, so it was really hard for me to sit there and say, for internal medicine, this is what the goal is. So getting input from other organizations and looking at other programs and what the overall goals were was useful. I also had the luxury when it came to the residency manual. I had no idea where to start. I was in tears, like, what do I do in this manual? What's the format? So I called one of our partners, and I just said, hey, any ideas? Can you give me any guidance? He's like, here's ours. So from there, it was just sort of tweaking it, and since it's one of our sites, I was able to just change, now we're the sponsoring, so it's just easy to sort of change some of that, but it really helped. So again, picking up the phone and just asking people for what they've done, I think most people are willing to share. You know, it's not like we're not competitive with each other per se. There's enough people applying to residency that, and I think there's no use reinventing the wheel, and you'll miss stuff. So getting somebody else that you know has already gone through accreditation and has passed is useful. So takeaway points, nothing really new on this. Just the partnerships, getting those CVs early, taking the time to really define your block schedule and what you want your curriculum to be is probably the key thing to know.